Hi everyone, we're getting set up. Thanks for your patience. We're excited for this next Tuesday training. Really grateful to Luna Vista Hospice for coming out today. Much love to them. We're going to be doing Hospice 101 here in just a jiff.
So welcome everybody, Hospice 101. My name is Josh Hernandez, I'm an LPN. I currently work with Luna Vista as a clinical liaison, working with hospice and home health. So a little bit about the history of hospice. The term hospice comes from the Latin word hospitum, meaning guest house. The hospice concept began in the Middle Ages with religious groups offering rest stops for pilgrims. Modern hospice care started in the 1960s in England with St. Christopher's Hospice opening in 1967. The first U.S. hospice was established in Connecticut in 1974, and in 1983, Medicare introduced a hospice benefit, which expanded in the 1990s to include nursing home patients. Okay, so the philosophy of hospice. Hospice believes that death to be a natural part of the life cycle. Hospice neither hastens or postpones death. Hospice supports patients who desire to die with dignity and have as much control as possible. Hospice aggressively manages pain and symptoms. It's holistic and recognizes that pain and suffering may be physical, emotional, spiritual, or social. And it supports the person in hopes that they may live as fully, as comfortably as possible. So quality of life. Some of the goals for hospice. They're to assist the patient in achieving the highest quality of life possible. It is accomplished by taking a holistic approach to the care and the patient and family by focusing on the mind. So providing emotional support to the patient and the family, the body, no longer curative treatment, but aggressively treating physical symptoms that occur as the body is shutting down. Spirit, providing spiritual support to the patient and family, which allows the spirit peace, which in turn enables the patient to pass away without distress and allows the family to have peace when the loved one passes away. Some quick facts. Each year, over 1.6 million Americans with life-limiting illnesses receive care from hospice providers. The median length of hospice care is 17.4 days, but over 35% of patients receive care for just 7 or less, limiting their ability to benefit from the full ranges of hospice services. Cancer accounts for 36.6% of hospice cases, with other leading diagnoses including heart disease, debility, dementia, including Alzheimer's, lung disease, and stroke. Most Americans, 8 out of 10, say they would prefer to stay at home surrounded by loved ones and facing a terminal illness. So when is it appropriate? These are guidelines and not necessarily all admitting indicators on evaluation for patients. So if the individual has dementia and is now speaking 6 words or less, increased shortness of breath and increased need for oxygen, has had long-term or repetitive problems with worsening symptoms, has cancer and is no longer seeking treatments, has chronic end-stage renal failure and doesn't want to continue dialysis, is having repeated falls, repeated infections, and repeated trips to the ER hospital. And in the last 3 months, if they lost 10 pounds and are not wanting to eat anymore. Hospice eligibility. Okay, so determine the appropriateness. So terminal illness conditions, with advanced cancer, for example. If their life expectancy is less than 6 months, Goals of care. Focus on comfort and symptoms management, not curative treatment. Disease progression, worsening conditions with limited treatment options, function decline, significant loss of physical abilities. Emotional and spiritual support needed from the patient and family. Decisions made in consultation with the patient and family. So the Medicare benefit. So with Medicare benefits, you can get skilled nursing, which is monitors the pain and the symptoms of the management. Physician oversight, making sure that everything is accurate for the patient. Medication management, anything that resolves and reverts into that terminal illness. Medical equipment, so if they need oxygen, hospital bed. Therapies for comfort aspects. Home health aid to help with personal care. Social services, offering counseling, and that goes to the family as well. Spiritual support, so it's tailored to what the patient and the family needs. And then after, the families receive 13 months of bereavement support. Curative treatments aren't covered, and non-hospice related medications or services. So the role of a caregiver. So hospice caregivers play a vital role in supporting patients during their final stages of life. They help with daily tasks, provide emotional support, and ensure comfort and dignity. Working closely with the hospice team, they help create a peaceful environment and offer compassion while also giving the family members much needed relief and support. So personal care assistance, so helping them with bathing, dressing, your everyday activities. Mobility support, do they need help getting in and out of the chair? Do they need help going to the bathroom? Meal assistance, helping them prepare their food or helping them eat to make sure that they're getting that accurate nutrition and hydration. Symptom management, helping them get into their comfort levels and making sure that anything that's not comfortable is reported. Medication administration, helping them take their medications as ordered by the physician. And of course, communication with the hospice team. If you see something, then they report. So with pain management, so it's a central focus in hospice. I always want to treat the pain and make sure that they're not struggling. So addressing and relieving pain through medication and non-pharmacological methods, depending on what the family and the patient and the doctor decide. So some additional symptoms. So respiratory symptoms, so having trouble with dyspnea, so having trouble breathing, using oxygen for assistance, constipation, so encouraging a high fiber diet and then resolving to medication if need be for that portion. Nausea, vomiting, same thing, medication. Some frequent meals, avoiding strong smells, sometimes gets nausea for the patient. Delirium and agitation. So there's antipsychotic medications for these that help in that instance as well.
Could you go back to that for just a moment?
Yeah.
I'm sorry, I'm not a fast reader.
No, not a problem.
I had a question also about the constipation. Like, I know that like our patients that we're caring for now in the Honora, we are giving them a lot of morphine, and that's a liquid, but they can't take anything like a stool softener, and I'm a little concerned about that. I don't know if I should just let that slide. Because, you know, when you can't swallow a pill, then you can't take your stool softener, you know?
Yeah.
And I don't know, I mean, if you're that close to the end of life.
Suppository?
Yeah, and there are other ways for that, like a suppository, depending on what the doctor orders. But if you do see something like that and you have questions about it, make sure to bring it up to your team. That way the physician can address it and give what's needed.
And a lot of times, too, if patients are towards the end of life and they're already taking the liquid pain medications, a lot of them aren't eating or drinking anymore, which means that they have less intake, which means less output. But yeah, we can do enemas, we can do stool softeners, there's other avenues besides like oral medication.
There you go.
So comfort and care. So always remember, keep the patient dry and clean, which we like ourselves, and following those things. Use pillows to support the body, whether they're turning them or what the instructions are from the doctor. Gently massage hands and feet, play soft music, familiar voices will always help. Maintain a peaceful environment, limit noise, lighting. Encourage presence, not pressure. So just be there with them. Listening without judgment, they're gonna tell you stories. Be open to silence. Sometimes they just wanna rest. Offer comfort, presence more than words. Encourage legacy projects and memory sharing. Welcome. So the dying process and what to expect. So understand the stages of dying helps you provide compassionate care in the final days to remember. So there's going to be physical changes. As death approaches, patients may become increasingly lethargic, unable to eat or drink, and have changes in breathing patterns. Psychological, emotional changes. Patients may exhibit signs of withdrawal, confusion, or desire to resolve unfinished business. They want to say sorry to somebody. They're waiting for that individual, that family member to come in. End of life signs may include a drop in blood pressure, irregular breathing, changes in skin color, and a slowing of circulation. And as always, call your hospice if this is done. See? And most of all, you want to make sure that you're doing self-care for yourself. It takes a lot of work sometimes. It takes a lot out of you. You become close to patients and you have that bond with them, that connection. So you always want to make sure that you do a debrief after you have somebody that passes away. You want to take your breaks. You want to do your own self-care, whatever it takes, whatever, if it's taking a walk, journaling, talking about it. Make sure that you're able to handle yourself. You can't take care of people if you can't take care of yourself. Okay. Questions?
Oh, I'm sure we have plenty. I want to know what order to give them to you in.
Shout out to Castle Coffee too for hosting this, and Jonah, my main man.